segments, and I'm going to talk first about just basic anatomy and function of the urinary tract and how it's affected in kids with spina bifida and other cord problems. And then Chad's going to talk about a little more of the advanced treatment and therapeutics like surgery and beyond medications and some of the basic stuff. So, sorry, that's right. That's okay. So I'll draw up here because I think I can probably explain a little better if I draw while I tell you about the bladder and kidneys and how they're affected. And then I'll stop and we'll try to leave plenty of time for questions. So when you look at urinary tract, mainly what we're worried about in terms of spina bifida or any cord injury is how the bladder is functioning. So the bladder is obviously a big, roughly spherical structure, and the urethra is the little channel. I'll draw a female urethra here. The male urethra is obviously just a little longer, but everything else is largely the same. And the bladder has a muscular wall. And the other important part of the sort of bladder and sphincter working together are the sphincter muscles that sort of go around, encircle the urethra there. And for a bladder to work properly, there's just a few basic things that it has to do. So the kidneys drain down into the bladder, and I'll tell you a little bit more about that. But as the bladder fills up, so what you really need is a big enough bladder to hold the urine for a period of time. The other thing you need is a sphincter muscle that will hold enough pressure at the bottom of the funnel to hold it in the bladder for a period of time until you're ready to go. So big enough bladder, strong enough sphincter. And then the final part to have normal bladder control is to be able to feel it and initiate a contraction of your bladder when you're ready. And those things can be pretty difficult if you have spina bifida or another cord problem because the nerve signals aren't all intact. So some of the signals may come, but not all. And those are the basic things that can get thrown off. So when we look at bladders and how the bladder's working in your kids or in you if you're our patients, one of the really helpful things is to do the CMG test. And let me tell you just a little bit about the CMG test. I'm going to draw you a little graph. But I think it's an important way to think about it. I think you can kind of get the basic idea of what we're watching and why it matters. I think as parents and patients, you'll have a little better idea of what you're worrying about and whether it's right or wrong. So when we look at the bladder, one way to study it is put a little catheter in the bladder that has two channels. And you can put fluid in through one channel and you can measure pressure in the bladder through the other channel. And then we can also put a little pad on the bottom that can measure what this muscle is up to. It measures whether it's squeezing or relaxing. And the CMG basically looks at those things. And so with the basic thing we can do with the CMG is we can make this graph that really helps me think about it. And I'll tell you some of this basic, simple way it works, the simple things that we get out of it. So the graph basically looks at how much pressure is in the bladder, and that we measure it in something called centimeters of water pressure, and then how much volume, which we measure in milliliters or cc's. So as we fill, we just measure how much we put in there and how much pressure is developing. And so we can make a graph of how the bladder is performing. Now a normal bladder would hold a lot before the pressure went up right at the end. And for most of us, that's where we'd be uncomfortable. But if the nerves aren't telling the bladder to relax when it should, generally the bladder will be quite tight. And that's the most common situation. Not all kids, but a lot. There'll be a tight bladder that doesn't relax well. And so in that case, as we fill the bladder, the pressure goes up a lot more quickly than we would like. And in terms of our bladder staying healthy, we want the pressures to be pretty low. So if pressures get up to a high level, then what we worry about as the urologist is two main things. We have this kidney up here, and the kidney's actually on scale would be way up there, but I'll draw it here. You have a kidney, and the little ureter that comes from the kidney, it comes down behind the bladder like this, and then opens inside. What should happen is the kidney makes the urine and pushes it down into the bladder, and the bladder holds it till you're ready to go. If there's too much pressure in the bladder, and I'll go back over and tell you a little bit more. One of two things can happen. Either it starts to back up to the kidney, and that's reflux. I think a lot of you guys have probably heard of the reflux problem. Or if the pressure in the bladder just holds it and doesn't get rid of it, then the kidney trying to push the urine down, the little muscles in the ureter are trying to push it into the bladder, they'll start to fail. Because if there's too much pressure down below, the kidney can't empty into that bladder. It starts to get dilated or develop hydronephrosis. You guys have probably, on the ultrasound, that's kind of what we're always looking for. Is there hydronephrosis developing? So we keep looking at the kidneys with patients with spina bifida, but they don't get directly affected. The kidneys are basically okay. It's just the bladder and the pressures in the bladder that can hurt the kidney over time. So that's one of the main things we're looking at. So reflux and hydronephrosis. So the one big way that this helps us is to know how much the bladder holds and at what pressure. One of the really important things that we can determine, if we sort of look at the individual pressures here for a patient. So let's say this is just one patient. Every patient's curve will be a little bit different, but this is one patient. We measure something that's probably a good one for you to remember. It's called the leak point pressure or the leak pressure. And for us, what that means is we start to fill the bladder, and then we see, let's say this patient's going to have a leak from their bladder when this much goes in and it reaches this pressure. That's when we can see things leaking around the catheter when we do the test. Well, then that informs us, and we say, okay, so we know that's when the leaking occurs, and this patient at that point, we'll just make something up, is held 100 mLs. And let's say the patient's age is such that the bladder should really be more like 300 or 350 at that age. Then we say, boy, that's a pretty small bladder. So in terms of being able to hold enough to go 3 or 4 hours before you either urinate on your own or use a catheter to empty the bladder, that's going to be a big challenge because that bladder is only a third normal size. Okay? So that's one way it helps us. The other big way it helps us is this patient, if this is one we've kind of made up, if this bladder leaks, and let's say the pressure, and don't worry about the numbers, but the pressure of 20 in the bladder when it leaks. So Dr. Wallace and I know that that's a pressure that's probably not going to hurt the kidneys. So that bladder will get up to 20, and then the leakage will start. But it'll never get up to the kind of pressure that inhibits the kidney from emptying well. And so if you or your child has a leak point that's low, that's a safe bladder in terms of kidneys and dilation of kidneys. The challenge is going to be, it's going to be harder when they're older to hold things in the bladder because that's basically a weak sphincter muscle because that's what's determining how quickly things leak. So if this same patient instead had a higher leak point pressure, let's say 60, then they could hold more, but the problem would be they're holding it at a really high pressure, and then we might see either the reflux start or the hydronephrosis start. So especially early in life, but through all life, but especially early, this is what we're watching for a lot, and that's why we get the CMG tests, and that's why we get the ultrasounds to look for hydronephrosis, to tell us kind of what's going on in the bladder and are we having any problems. And if Dr. Wallace and I were to sort of list goals that we have for your kids or for you as patients, probably number one would be, I'm just speaking as a urologist here basically, protect kidneys. And that's pressure is one thing. Next is decrease or minimize urinary tract infections because those can harm the kidney too if you have too many of them. The third is to eventually be dry and not leak. So that's a little other discussion. And then the fourth, and to include all these things, is basically to create sort of an independent, and fulfilling way to take care of these things. Something that's not a huge burden, and to do our best to sort of figure out how you can do it at work and do it at school and integrate it into being a real person and having a real life and not just having to worry about bladder stuff is a principal thing. So that's kind of what we look at there. A couple basic things that I'll let Dr. Wallace talk a little bit more about what the potential therapies can be if the simple things don't work. Some patients don't need us to do anything. There are some patients with really low lesions who can have adequate bladder size and sensation and squeeze at their bladder if they can pee on their own and do well. Other patients where the bladder is more effective, which is much more common. One of the big issues is the bladder won't squeeze. It has little squeezes or these big spasms that aren't very coordinated, but it doesn't empty the bladder out properly. A little may leak, but it doesn't empty completely like we'd like to see a bladder do. And as lots of you guys know, that means using a catheter to drain the bladder. So the catheter can keep the pressures low in the bladder, and it also is very helpful that the bacteria that get into the bladder and tend to sit there, if you don't cath, they can sit and multiply because the bladder never empties out all the way. But with cath, even if the bacteria get in, as long as we empty them periodically with the catheter, they don't tend to set up shop and cause a real UTI. So cathing has the pressure reduction help, UTI help, and often it's required to be dry. So the catheter usage has been a huge help for patients with spinal cord problems, including spina bifida. The other thing that's pretty common will be medication. Basically, basic medications that go with cathing. One of those is oxybutynin or ditropan, and there are a bunch of other basically variations on the theme of ditropan, a bunch of other names and medications that work the same way, but here's what they do. So if this is what your bladder does, then ditropan will basically take the bladder muscle and relax it and move down this way. So it moves the bladder filling curve this way, which means for every extra amount that gets in the bladder, the pressure stays a little lower. Okay, so it can help make the bladder work like it's bigger. It has a different response in everyone. And there's one other little part to the ditropan, and then I'm going to let Dr. Wallace talk about some things. If you look at a filling curve, I sort of drew an ideal curve here. What we'll see in real life is something like this, where during the filling, there'll be little spasms of the bladder where the pressure will spike up, and some patients it'll be really dramatic, and others not very dramatic. The ditropan also tends to knock those little peaks down, so you won't have as many spasms, and your bladder will relax more. So, just an example would be, let me draw you this. So let's say, just in day-to-day clinic, so let's say we just make up a patient here who has a leak point pressure of 30, and we do the CMG. So let's make it a 9-year-old patient, and they've been doing pretty well, not many infections, but they're leaking between catheterization, cathing every 3 hours and still leaking. So we do the CMG, and we find that the CMG sort of does something like this, and works its way up, something like that, which those are spasms in the bladder, but also a bladder that's not relaxing well. We'd kind of say, all right, let's say in this patient it's 150 cc's, and we think the patient should really hold more like 250 or 300. That's how much they can hold and still cath every 3 to 4 hours and be dry. What we'll do is try one of those medications first to see if we can reduce these spikes, because anytime this spikes up above where the bladder leaks, that's when you're going to have a wetting episode, because the pressure gets up to be more than this muscle can hold. And so the ditropan would be our first thing to try to knock the peaks down and move this so you can hold more without the pressure ever getting over the worrisome point. All right, so that's the basics of bladder, and then Dr. Wallace is going to talk to you a little bit more about if those things are a challenge or not successful, what else is possible.